Hello, in series of orthopedic learning videos. In this video, we'll talk about specialized minimally invasive tense nail system in pediatric humerus fracture. This video is going to be quite helpful for young orthopedic surgeons. Pediatric humerus fracture fixation with titanium elastic nail. Commonly, these fractures are treated conservatively with functional bracing, use slab, hanging cast, sling immobilization, or some splints. Principle of conservative treatment method is that the newborn and the infants have a high remodeling potential up to 45 degrees of deformity remodeled with the growth. Greater mobility of the shoulder joint also have the added benefit for the functional outcome in conservative treatment of fractured shaft humerus. Operative treatment is indicated in the indications with the fractures with grade 1 or grade 2 compound injuries, fractures associated with other long bone fractures, the fractures associated with systemic injuries in the body for the early rehabilitation of the child, or when there is a complete displaced fracture fragments. Plate osteosynthesis is not recommended for the infant or the pediatric humerus fractures due to the violation of rotator cuff or the impingement of shoulder muscles. Antegrade nailing is not preferred. Titanium elastic nail fixation is an ideal procedure for pediatric humerus fracture. It's a minimally invasive procedure, simple, well reproducible technique, and a very low complication rate. The three distal entry portals for titanium elastic nails are lateral entry portal, which is epicondylar entry just to prevent the entry in the joint and to interfere with the joint motions. Second, the medial entry, and the third, the supracondylar entry. This is an example of a displaced pediatric proximal humerus fracture, which is an ideal indication for fixation with tense intermedullary nailing. The appropriate size of titanium nail is calculated by multiplying the narrowest diameter of medullary canal of the humerus by 0.4 in centimeters. The lateral is always the preferred entry portal. For the preparation, we make a small incision 0.5 to 1 centimeter on the lateral aspect of distal humerus, just proximal or about to the lateral epicondyle, and before inserting the nails, they are pre-contoured manually into a C-shaped configuration for further manipulation. Preparation of the lateral entry point. The entry point is always made 1.5 to 2 centimeter proximal to the physis with the help of an awl or a drill bit. The cortex is opened gently with 3.2 or 4.5 mm drill bit, depending on the desired size of tense we are planning. The drill bit is always advanced under image intensification. After making entry with an awl, the tense nail of prefixed size is passed gently through the lateral entry, and it is pushed with a slow movement till it reaches to the opposite cortex and stop. These tense nails are pre-bent before insertion, and we rotate it slightly inside the medullary canal so that the convex surface is facing towards the opposite cortexes. This helps in sliding the nail forward with a gentle movement and prevents the piercing out from the opposite cortex. As we reach close to fracture site, we stop the forward push and direct the tip of the nail towards the medullary canal of proximal fragments. This helps us for easy negotiation through the fracture site. Second tense nail entry, that is supracondylar or supraorbicularis fossa, is always marked with KY under C-arm guidance. In this process, we avoid hammer or the heavy force to avoid supracondylar humerus fracture complications. Then the entry is widened with a wide, smooth, sharp bone awl for the easy passage of the tense nail. As we push the second nail inside, we always try that the convex surface is facing towards the anterior cortex to avoid piercing to the anterior cortex. Then with this gentle rotatory and the push movements, the second nail is pushed in the medullary canal. It passes along with the first nail, and the C-arm guidance we continuously push it proximally. When we reach to the tip of the second nail, which is already stationed close to the fracture site, we stop. Under C-arm guidance, we look at both the directions, AP and the lateral view, and we decide the tip position so that it can easily negotiate to the fracture site and enter in the proximal fragment. Under C-arm guidance, we check nail head positions in AP, oblique and the lateral view. We check and cross-check it. Try to reduce the fracture and with external manipulation. Then under C-arm guidance, one nail is pushed and negotiated to the fracture site. Simultaneously, the second nail is adjusted and is pushed along with the first nail in the same track to the fracture site. As both the nails cross through the fracture site, under C-arm guidance, we try to direct the tips of both the nails in opposite directions so that they can give us a spanning effect, which is very important for the rotational stability of the fracture site. This rotational stability can be cross-checked with the movement on table under C-arm, and with AP lateral views. If we require, we can do final adjustment of the tip of the nails so that we can have a stable fixation. Post-tense fixation, we immobilize the arm in U-splint or POP slabs. This immobilization is maintained till 2 weeks. At 2 weeks, we remove slab and start gradual shoulder pendulum exercises along with elbow mobilization. At 4 weeks, we start assisted overhead movements. At around 10 to 12 weeks, the bone union is assessed on the repeat X-rays. If it's satisfactory, we plan removal of tense nails under anesthesia. The exercises, shoulder and the elbows are continued, and the patient is advised to avoid outdoor sports for the next 4 to 6 months. In the sequence of educative videos, we'll keep on posting such more videos for the young orthopedic surgeons. You can put your questions in the box. Thank you very much.